Good evening, good afternoon, and good morning, wherever you are safely located. Welcome to this ESRA industry partner webinar in conjunction with Pajunk. I'm extremely delighted to be presenting to you together with my fellow colleagues for the next hour, discussing about rectus sheath catheters used in post-operative analgesia for midline laparotomies. My name is Andy Ng. I'm a consulting anaesthetist and acute pain lead at Blackpool Teaching Hospitals. Just a couple of housekeeping slides. This is a non-CME webinar. There are certificates of attendances available if you want to email Pajunk directly on the marketing email. We do have a question and answer feature after the end of the presentations. Please use the Q&A icon in on your device, and I will be reading out the questions during the Q&A session at the end. The webinar is being recorded and it will be available after the end of this recording on Pajunk's YouTube channel as well as the ESRA webpage. Without further ado, I would like to introduce the first speaker, Dr. Anton Krige. Anton is an esteemed colleague of mine who works in intensive care and anesthesia at Royal Blackburn Hospital. He's also an honorary professor at the School of Medicine, University of Central Lancashire. And I had the great privilege of working with him as a trainee. So it's a real pleasure to introduce him, and I'll let him crack on with the first part of the presentation. Anton will be presenting on the how, or the evidence bit of the rectus sheath catheters. Over to you, Anton.
Thank you for that kind introduction, Andy, and good evening, everybody. I'm giving the first of the two lectures, and they should gel quite nicely together. This one is about the current evidence for rectus sheath catheters, really the sort of why to do them. And Madan's going to follow on after me presenting on how to do them and the techniques involved. So hopefully you find this of interest and of use. My disclosures, I have no financial disclosures. I was the recipient of a major National Institute of Health Research grant to conduct a randomized trial on rectus sheath catheters some years ago. And I was co-editor of this textbook on analgesia for abdominal surgery and co-authored the chapter on rectus sheath catheters. Just for reference, for those who are completely unfamiliar with the technique, this is sort of what a patient looks like with rectus sheath catheters. This is a patient of mine from probably a decade ago. He'd had a Hartmann's procedure the previous afternoon, and this is the following morning. We can see over here the insertion points of the rectus sheath catheters just over the costal margins, well above the midline laparotomy incision, and they've been tunneled out onto the chest wall. And the catheters are connected to a infusion pump in a bag slung around his shoulder. We can see that the century blockade from T6 to T12 lends itself perfectly to analgesia for midline laparotomy incisions. And that's really what we're going to explore in this talk. Really, the evidence starts much further back than what you'd realize. The gentleman on the left, a German surgeon, Karl Schleich, he first published a description of this technique, and this is in 1899. So well over 120 years ago. And he actually beat the description of epidural blockade by 2 decades, which was described by Fidel Morave on the right. It was initially used up until the discovery of neuromuscular blockade primarily as a means to relax the abdominal wall during surgery. And it really disappeared for probably 100 years until catheter techniques were developed and described as recently as 2007 with surgical placement by Cornish and Deacon. And the year after that, 2008, a description by Sanderman of ultrasound-guided placement. So really, this is a pretty new kid on the block. And the remainder of this talk, I'm really dividing into 3 sections, because the way I see analgesic techniques is really, are they effective? Are they safe? And are they acceptable both to the patients and the staff? Those are sort of 3 umbrellas under which I look at techniques. And starting with the one which is the bulk of the talk, the effectiveness, this is of course much more than just a pain score, which is really what most pain studies report on primarily. That really just tells us about pain intensity. We're more interested in what a patient can do. So we're interested in functional analgesia, how well can they walk, mobilize, sleep, and essentially do enhanced recovery. As we see in this same patient, we saw in the picture earlier, he's mobilizing a few times around the ward that same morning, first morning following surgery, and he's just eaten his breakfast. So that's what we're after for effective analgesia. Now, there have been a plethora of studies since that first description of the technique. Really, as all studies, new techniques start off by comparing to placebo and opiate. I'm not going to cover those. They largely find rectus sheath catheters superior to pure placebo. But we're really interested now in comparing in randomized trials to active comparators. And the first of these is as recently as 5 years ago. And this first study out of Egypt compared rectus sheath analgesia to continuous wound infusion catheters. The two are often confused, but they're distinctly different procedures. And the rectus sheath catheter group is the group in red, and we can see that they had significantly lower pain scores on movement than the continuous wound infusion catheter group, as well as significantly lower morphine consumption. Group 2 in this case is a rectus sheath analgesia group, group 1 being the continuous wound infusion catheter analgesia. In the same year, we've got the first comparison to epidurals, and that's going to be the remainder of our RCTs are going to focus on this comparison. With epidural, by and large, still being considered as the gold standard for analgesia following laparotomies. And this study of 50 patients following gynae-oncology surgery, they found largely in terms of pain scores, fairly similar scores. And in terms of ambulation and gut recovery, again, fairly similar between these 2 groups. The following year, we have a first of a couple of studies coming out of Egypt, 2017. And this group looked at a different surgical cohort. This is upper GI surgery, upper abdominal surgery. 60 patients, 30 in each group, again, compared to epidurals. And although not unexpectedly, the rectus sheath group require more morphine on the first day, very clearly this provides very effective somatic analgesia abdominal wall, but cannot deal with visceral analgesia. That still requires opiates or some other form of pain relief, but this is largely subsides after the first 24 hours. So, despite that extra opiate consumption, we can see that both groups had similar and very low pain scores at rest and following coughing. And despite that difference in opiate consumption, the rectus sheath group were earlier to mobilize, and significantly so. This study by Turkey et al., also from Egypt, the largest of the published studies to date, 100 patients, major cancer surgery. Across the board here, you can see very low pain scores in both groups, but no difference between them, both at rest and following coughing, 2s and 3s out of 10. And then we have all these aforementioned studies. We're comparing intermittent bolusing of the rectus sheath catheters compared to either intermittent bolused epidurals or fixed rate epidurals. This study out of India was comparing continuous infusion, 10 mils an hour, through the rectus sheath catheters to a continuous infusion of local anesthetic only thoracic epidurals. They found low opioid consumption in both groups with no difference, but lower pain scores in the rectus sheath catheter group, reaching significance at rest at 12 hours and at a few other time points following coughing and following movement, all in favor of the rectus sheath group. We conducted this study, the so-called Turks Study. It's currently undergoing review and hopefully soon to be published. When published, it will be the largest one to date. We recruited 131 patients who'd undergone either major colorectal surgery or radical cystectomies. And looking at pain scores at rest, early pain scores were acceptable in both groups, but better in the epidural group. But the late pain scores, specifically at 72 hours, as you can see, reached significance in favor of the rectus sheath analgesia group. On movement, largely better in the epidural group, but still acceptable pain scores, and only reaching significantly better for the epidural group at 24 hours. Movement, is defined at the patients moving by themselves from lying completely supine to sitting upright in bed. So quite a significant pain stimulus. One of the differences between our study and perhaps these difference in findings here to the previous RCTs is that this is more of an effectiveness study in that we did our best to optimize both groups. So our epidurals were optimized, and the epidurals also included our standard solution of bupivacaine mix of fentanyl. All the other groups were compared to epidurals who are either fixed rate and all were plain local anesthetic epidurals, which we know are not as effective. So this was a more a real life comparison. Looking at intervention failure rates, these were lower in the rectus sheath group. And largely most of them in both groups are due to disconnection or dislodgement of catheters rather than failed blocks. In terms of opioid consumption, interestingly, our study had lower opioid consumption on day 3 in the rectus sheath group. And in terms of functional analgesia, there were no differences in terms of sleep quality, respiratory function, or the ability to mobilize. Nor were there differences in return of gut function and stay in hospital. We also looked at a validated recovery score called the PQRS scale, where patients are scored in a wide range of domains prior to surgery, and then the percentage of return to baseline is compared on days 4, 7, and 30. As indicated in this slide, there were no differences. However, of interest at day 30, a full month after surgery, we can see large proportions of patients in both groups had still not recovered their cognitive function or emotive functions. In terms of health economics, this was a limited assessment, really taking into account length of stay differences in terms of mean stay and procedural costs. And yeah, we saw significant savings per rectus sheath catheter. This would have to be further confirmed with larger studies, but is certainly of interest. And in keeping with this, the study published from coming out of Cornwall in England showed acute pain teams having significant lower requirement for both post-op visits, time spent reviewing, and dealing with problems in the rectus sheath group compared to the epidural group. And you can see the epidural group having almost twice as many problems, 27 versus 15 for the pain teams. The final section of studies that I'm going to cover in this effectiveness section are really looking at a few interesting concepts about ways in which we can further improve the quality of rectus sheath blockade. And this study looked at whether the addition of morphine to the bupivacaine compared to bupivacaine alone had an influence on the block. And yeah, we can see that the group, which is the study group, in blue had significantly lower pain scores both at rest and following movement than the group of bupivacaine only, as well as significantly lower systemic morphine consumption. So certainly worth considering adding or mixing opiate with the local anesthetic to enhance the rectus sheath block. Not only that, but it led to a significant increase in patients being able to mobilize. And we can see at day 2, the group with the morphine added 100% had mobilized, with just over a third managing to mobilize in the control group. And this translates into a 2-day shorter hospital stay. We know in many other nerve blocks that dexmedetomidine can enhance the block. And this Chinese study looked in a single shot rectus sheath block in a cohort of high-risk elderly patients at what influence that had on the rectus sheath block. And we can see here that it indeed significantly reduced the requirement of sufentanil post-operatively. It lengthened the duration of the sensory blockade and significantly reduced the PCA usage. We can also see in the graph below that it had a significant improvement in the pain scores. One of the other questions surrounding rectus sheath blocks is whether intermittent boluses or continuous infusions are better. This recent Finnish study, 2018, had 3 arms, a control arm with placebo, compared to an intermittent bolus arm and a continuous infusion arm. They reported that the intermittent dose arm did seem to have greater opioid sparing efficacy and slightly better patient satisfaction. I would caution, however, though, our personal experience, and I've been doing these since 2011, although clinically the intermittent bolus seemed to provide a better quality of block, there's a much higher risk of non-compliance with delivery of the intermittent bolus on time and missed boluses. And overall, we've found the continuous infusions to be more reliable and to guarantee delivery. Another question always posed is whether there's any difference between initiating the rectus sheath block prior to the surgical incision or afterwards, which they sought to answer in this study. Again, this is just single shot blocks, not catheters. This was a gynae patients undergoing open midline incisions. It was a double-blinded study. Both groups got a before and after rectus sheath injection, but they changed the order between whether it was saline or local anesthetic before or after. And interestingly, the quality or amount of deep sleep as measured on BIS was significantly greater in the group who had the pre-incision rectus sheath block injection. And it's hypothesized by this group that this was due to a quicker reduction in IL-6 levels in the pre-incision group. So that's interesting. Moving on to the section looking at safety. We looked at this in our study, both in terms of morbidity, the post-operative morbidity score day 5, and dendoclavian complications. There were no difference between the 2 groups. Not unexpectedly, the epidural group had far higher incidence of hypotension and its surrogate vasopressor dependency, almost half of the patients. And this likely indirectly led to greater fluid overload, which we know is very important in enhanced recovery. We looked at this using a surrogate of day 3 weight gain from baseline, which was significantly greater in the epidural arm of the Turks study. And indeed, adverse events directly attributed to the interventions were 3 times as common in the epidural group compared to the rectus sheath catheter group. One of the potential complications to be aware of is inadvertent epigastric artery puncture leading to abdominal wall hematoma. These are fairly rare, only a few case reports in the literature, and should largely be avoided using ultrasound-guided insertion or with surgical placement, the surgeon clearly palpating for the artery and ensuring that needle insertion is within the so-called safe zone. The other potential complication we're always concerned about with any technique involving local anesthetic is local anesthetic systemic toxicity. This systematic review in the British Journal of Anaesthesia looked at this, and they included a subgroup where there was of 5 studies rather, involving single shot rectus sheath block. None of these breached the theoretical toxic threshold of 2 mics per mil, which you can see at the top of that graph. However, we did look at this in a subgroup of our Turks study. We can see here in the continuous epidural infusion arm of the study receiving bupivacaine, they stayed largely below that red line toxic threshold. However, our intermittent bolus 0.2% 40 mils of ropivacaine did exceed that theoretical toxic threshold in half of the cases. However, none of them had clinical symptoms, but this is still of concern, and that was another reason we subsequently moved to continuous infusions. We looked at some neuroendocrine response to surgery and inflammatory responses, and looking at this in terms of glucose, insulin, and cortisol, there was no difference between the 2 arms in our Turks study. Although of note here at baseline, there's definitely more anxiety present in the epidural arm with the prospect of the epidural, with higher cortisol levels on the day of surgery pre-insertion. In terms of IL-6 levels, no difference between the 2 groups. Another complication to be aware of, and this largely happens with surgical insertion, and I've seen 1 or 2 of these in our center, and that's knotting of the catheter. Something to be aware of, and if it does happen, it potentially does require a return to theatre to remove it. In terms of acceptability of the technique to patients, this hasn't really been explored very well in the literature. We looked at it firstly in terms of surveying our patients regarding their satisfaction at the end of day 3 post-op of their analgesic experience of that entire 3 days. And we can see that more of the patients scored their analgesic experience as excellent in the rectus sheath group. And we, rather novel compared to most studies, used a mixed methods approach and included a nested qualitative study, which has also been submitted for publication. And that involved an in-depth interview of a subgroup of 10 patients from each arm of the study a month following surgery, where their experiences were explored in greater detail. The key findings from that was the very high levels of anxiety that the prospect of epidural analgesia engendered, and the fact that they were very laxed about the idea of having rectus sheath catheters. So this was a major finding in that component of the study. Going forwards, as we all know, there's the numbers of patients requiring midline laparotomy for planned elective surgery are dwindling rapidly and have largely been replaced by minimally invasive approaches, or for open surgery, mostly transverse incisions. None of these require rectus sheath catheters, or they're not appropriate. But really, the real niche of rectus sheath catheters going forwards will be this emergency laparotomy group. We can see, as by NELA registry in the United Kingdom, we record well over 30,000 emergency laparotomies per year. So this is a massive and very vulnerable group. And in keeping with this, the findings of the Turks study have partly been responsible for generating a major grant call from our National Institute of Health Research in the UK, where their health technology assessment program have put out a call for a £2 million grant to run a very large multi-center study to compare rectus sheath catheters in emergency laparotomy. And that grant should be awarded in the next few months, and that trial commence within the following year. And that concludes my talk. And this concluding slide I leave you with is that I've hopefully presented some evidence that this technique is worthy of consideration in being both effective, safe, and acceptable.
Thank you very much, Anton. I remember listening to your presentation on rectus sheath catheters back in 2013, and the evidence base was very compelling back then, and it looks like it's grown, significantly over the last couple of years. Now that the audience is hopefully convinced and by your evidence presentation, I would like to hand over the mic to Dr. Madan Narayanan next. Madan is a consultant anaesthetist and intensivist at Frimley Park Hospital down in Surrey. He's quite a prolific producer of excellent educational YouTube videos on regional anesthesia. I'm quite unashamed to say that I've used his videos for my own educational purposes, as well as sharing it with trainees. So without much further ado, I'll hand the mic over to Madan. Thank you, Madan.
Thank you very much, Andy, for the kind introduction. Are you able to see the screen and hear?
Yes, I do from my end. Thank you.
Okay, perfect. Right, I'm going to talk about rectus sheath analgesia and the practical tips. This is my affiliations. I work as a consultant in anesthesia and intensive care at Frimley Park Hospital. It is a small but a busy district general hospital in the southwest of England, in Surrey. It's got an active fellowship program, and we tend to train at least 2 to 3 regional fellowship trainees every year. I would like to acknowledge some of the slides the patients consented, and much of these are my own views and my experience. So the roadmap that we'll be talking about is first on anatomy, then Sono Anatomy and the scanning techniques, then a few indications, then I'll just talk about how I do the blocks and why I do it in certain ways. And then some common pitfalls and practical tips, especially on catheter techniques. The abdominal wall, as you're all aware, is covered by 3 concentric flat muscles, which are the external oblique, internal oblique, and transversus abdominis. As you cross the midclavicular line, all the 3 abdominal muscles become aponeuroses, and then they enclose a paired central muscle, which is the rectus muscle, which extends from the pubic symphysis to the xiphisternum. So the abdominal aponeuroses enclose the rectus muscle in 2 sheaths. One is a sheath which goes above, which is the anterior rectus sheath, and a sheath which goes behind it, which is the posterior rectus sheath. The aponeurosis fuses in the midline to form the linea alba. The anterior abdominal wall is supplied by the thoracoabdominal nerves between T6 and L1. L1 is the ilioinguinal and iliohypogastric nerves. If you see a typical cross-section of the intercostal nerves, they are the ventral primary rami of the intercostal nerves. Once they enter the paravertebral space, then after that, they enter the intercostal space, and at the mid-axillary line, they give the lateral cutaneous divisions, which enter the serratus plane or the external oblique fascia plane, after which the anterior cutaneous division travels in the intercostal plane and exits under the costal margin, which is over here, and enters the tap plane, which is over here. So after entering the tap plane, the nerves continue forward, and at the lateral edge of the rectus sheath, which is over here, they penetrate the rectus sheath and then enter the posterior surface of the rectus muscle, which is over here, and then they come out anteriorly and form the anterior cutaneous divisions. There is extensive cross innervation at the midline. They form 3 plexuses. One is the intercostal plexus over here, where there is a lot of communications. Then there's the tap plexus, and then the rectus sheath plexus, which is seen in the posterior rectus sheath. The ilioinguinal and iliohypogastric nerves, which is the L1 dermatome, does not travel within the rectus sheath. A typical Sono anatomy, if you place an ultrasound probe at the lateral edge of the rectus muscle, you'll see a cross section like this. And the way the ultrasound image will look like is this way. The first muscle, the muscles are seen as hypoechoic with hyperechoic stripes in between, and they are covered by fascial planes. So this is the external oblique, the internal oblique, and the transversus abdominis. The external oblique aponeurosis goes on top of the rectus muscle to form the anterior rectus sheath. The internal oblique splits into two aponeuroses, an anterior slip, which joins the anterior rectus sheath, and a posterior slip, which goes behind the rectus muscle. And this is the transversus abdominis muscle, which joins and forms the posterior rectus sheath. And this is the location of the linea semilunaris. You'd have heard about tram lines, which are constantly talked about in the performance of a rectus sheath block. The tram lines basically just means the posterior rectus sheath and the transversalis fascia, which look like the tram lines. If you see a cross section of the rectus sheath at different levels, it has got different functional anatomy, so which is very relevant in performing a block. At the level of the costal cartilages, high up in the abdomen, you'd see only the costal cartilage, which is a bright white line with a dark shadow underneath, the rectus muscle going above the costal cartilage, and the external oblique aponeurosis going on top of the rectus muscle, which is what you see in this cross section. At a level which is between the xiphisternum and the umbilicus, which is called the transpyloric line, you see the typical cross-sectional anatomy, which I had shown before, the external, internal transverses, and they splitting to enclose the rectus muscle. If you go below at the level of the anterior superior iliac spine, what happens is all the fascial layers and the aponeurosis go only on top of the rectus muscle, and there is no posterior layer. So the posterior wall is only by the transversalis fascia and the peritoneum. So if you see this cross scanning video, as the probe is moved from lateral to medial, the three abdominal wall muscles, the splitting at the linea semilunaris, and then enclosing the rectus muscle, the tram line formation, and as you go much more medially, you get the narrowing down to form the linea alba, and then you'll get the opposite rectus on the other side. And if you scan from cephalad to caudad, normally you see the transverse abdominis come first behind the muscle, and then after that, at the transpyloric line, all of them become aponeurosis to enclose. And as you go lower down, you could start to see all the aponeurotic layers traveling on top of the rectus muscle and the bowel coming closer. So below the arcuate line, there is no posterior rectus sheath, and you could start to see the origin of the inferior epigastric vessels, which travel on the transversalis fascia. So when would I do a rectus sheath block? So I would do a single shot block for umbilical hernia repair, either as a concept of a multimodal analgesia or to do them awake, for midline laparoscopic surgery, for pyloromyotomy, or for peritoneal dialysis catheter insertions. Continuous catheter techniques is for midline laparotomy for any reason, either upper GI, colorectal, gynae, oncology, vascular, or urology. I would talk about both a single shot and a continuous catheter technique because I tend to use the combination of both during a catheter technique. How do I do it and why? So I use an aseptic no-touch technique for doing a single shot block, but to use a catheter, you should be performing them with strict asepsis. With the patient in the supine position, vast majority of the times, you just need a linear ultrasound, 6 to 13 megahertz, and a 50 millimeter needle. And for a catheter insertion, a 16 or a 18 gauge Tuhi and a 19 gauge or 18 gauge catheter is chosen. What is the right level of insertion of a rectus sheath block or a catheter? So in order to say that, we need to look at the success and the safety. So if you see the vasculature of the abdominal wall, the superior epigastric vessels come from the internal mammary. They travel within the body of the rectus muscle, and then the inferior epigastric vessels travel in the posterior rectus sheath, and they form a plexus at the level of the umbilicus. So in this cadaveric study, which used ultrasound to assess the vasculature, what they found was at the transpyloric line, which is between the xiphisternum and the umbilicus over here, they found the vast majority of the superior epigastric vessels is intrarectus. As you go lower down to the umbilicus, they travel into more in the posterior rectus sheath, and as you go below to the level of the anterior superior iliac spine, almost all of it is behind the posterior rectus sheath. So 54% in the intrarectus at the transpyloric, so which means you avoid going through the muscle and use an upper neurotic approach through the linea semilunaris. At the level of the umbilicus, there's a high chance that you could encounter a vessel through the muscle or even in the posterior rectus sheath. So the higher you go, the more protection you have. This is the transversus abdominis muscle, which is present behind the rectus abdominis, so that it offers an extra layer of safety. So what should be the ideal direction of needle insertion? Lateral to medial, medial to lateral, or craniocaudal? So there is evidence to suggest that a lateral to medial approach is much preferred than the other approaches. If you see the typical anatomical distribution, all the thoracoabdominal nerves from T7 to T12 enter at the lateral edge of the rectus sheath. You can see that, and they travel for a distance between 1.5 to 2.5 centimeters in the posterior rectus sheath. They perforate the rectus muscle and they penetrate anteriorly. So it makes sense to do a lateral to medial approach on anatomical grounds so that all these nerves could be covered. But does that translate into in cadaveric studies? So in this cadaveric study, which looked at this question, which is a lateral to medial injection versus a medial to lateral injection, and looked at the spread of the dye and the number of nerves that were stained. What they found was a lateral to medial injection produced a greater staining of the nerves compared to a medial to lateral injection, where there was a lot more sparing of the nerves. So does this matter in clinical practice? Yes, it does. In this study, which used predominantly just a medial to lateral approach to perform awake umbilical hernia repair under rectus sheath blocks, what they found was the block was effective only in half the patients. Almost all of them required cutaneous supplementation at incision. What they also looked at was the spread patterns of the local anesthetic on ultrasound. When there was a good spread seen to the lateral edge as well as above and below, what they showed was the block was 75% effective. That is, they did not need more supplementation. None of these patients required a conversion to GA. What they concluded was that a lateral to medial injection probably improves the performance of the block. What about a craniocaudal injection? As we have discussed before, the rectus muscle is a longitudinal muscle which originates from the pubic symphysis and goes up to the xiphisternum. In a craniocaudal approach, the muscle fibers are all parallel and aligned like this. When in-plane needling is done, an inadvertent intramuscular injection produces lots of false layers. So you are more likely to thread a catheter into a false layer and cause catheter failure. So this process is called as a lamination. So this is why we would tend to recommend doing a transverse approach to identify the plane. And how about ease of performance of a block? In this study, which looked at the learning speed of people when they do across the visual axis, which is this one, where the needling is done across the visual axis with the machine placed in front or along the visual axis, what they found was the ability to learn the technique was much faster with the along the visual axis. And the needle was kept in vision for a much longer time, and the time to perform the task was much shorter. So along the visual axis is a much better technique, which all means together that the lateral to medial approach, where you go through the upper neurosis, avoid a direct muscle injection, and avoiding the vasculature is a much safer technique to do. What is the end point and what is the ideal spread pattern? The end point is to be between the muscle and above the two tram lines. These are the two tram lines. The end point should be to lift the muscle of the posterior rectus sheath. So which you could see in this animation. You should see a lentiform spread of local anesthetic, which spreads downwards. In this cadaver study, which looked at an injection which is placed above the tram lines and between the tram lines and looked at the spread of yellow dye. What they found was when the injection was placed above the tram lines, the spread was much higher from T7 to T12. But when they were placed between the tram lines, they spread only between T7, T8 to T10. That is, they spread only on the transversalis fascia. So their clinical efficacy could probably be lesser. In this video, you could see the needle entering from the lateral to medial approach, puncturing through the muscle and scraping the posterior rectus sheath. And an injection is then made to lift the muscle of the posterior rectus sheath. You could notice the bevel of the needle is facing the posterior rectus sheath to ensure that parallelity is maintained. And you could see the lentiform spread of local lifting up the muscle. So the key is volume. So 20 mils of 0.25% ropivacaine or 20 mils of 0.2 ropivacaine on each side is our standard practice. If you were to compromise on the concentration, you can increase the volume of the local anesthetic that can be placed. As shown before, this systematic review, which looked at the plasma concentrations of local anesthetics following bilateral tap blocks or rectus sheath blocks, showed that the plasma concentrations of rectus sheath blocks were much lower than the tap blocks, and they attained them at a much longer time. So which is nearly double the time, an hour compared to 30 minutes for the tap blocks. That shows that the rectus sheath block has got lesser vascularity and a lesser surface area for raising the plasma concentrations. This has got implications for the technique that you're going to follow afterwards, either a bolus or an infusion technique. Some of the pitfalls of the rectus sheath block are, it's a somatic block. As Anton had mentioned, you may still need to give them opiates as it does not provide visceral analgesia, but vast majority of them, after the first 24 hours, the visceral pain goes away. It provides analgesia for midline procedures and up to the mid-clavicular line. Any lateral skin incisions or stoma or drains, they're not covered. So patients may need extra opiates. It needs bilateral block because of extensive cross innervation across the midline. And the L1 dermatome is typically not involved, which is the ilioinguinal and iliohypogastric territory. But there have been studies in gynecological surgery where they have used rectus sheath blocks for fan and steel incisions. Failure is a common problem, but it could be due to anatomical reasons rather than technical reasons. In this cadaver, it shows lipomatous degeneration of the rectus muscle, which prevents the spread of dikephalate. The older you are, the more likely you are to develop lipomatous degeneration, and there could be failure of spread in the posterior rectus sheath. Previous surgery with adhesions and the nerves not traversing the usual route. Nearly 85% of the cases, the nerves enter the lateral edge of the rectus muscle, and they penetrate through the muscle and come out anteriorly. But in around 15%, they do not penetrate the rectus muscle and they come out anteriorly without going through the body of the muscle. In this study, which used a combined anterior and a posterior rectus sheath block, what they found was the block was much more effective in terms of the patient's analgesic request afterwards. But as the anterior rectus sheath has got tendinous insertions, the local anesthetic spread may be very much dermatomally restricted. So there are a few other things that you got to watch for, especially subcostally. This is the linea alba, and this is both the rectus muscle. This is the left lobe of the liver in a thin individual. So you got to be aware of vital structures. And this is a typical rectus muscle in a muscular patient with the tendinous insertion. And this tendinous insertion is of the aponeurosis. So which means an anterior rectus, when injected under the anterior aponeurosis, wouldn't spread effectively because of the tendinous insertions. Continuous catheter technique. So we do around 300 to 350 laparotomies every year, and nearly 90% of the post-op analgesia, this is just emergency laparotomies, Nearly 90% of them tend to receive rectus sheath catheters for post-op analgesia, and a few of them require subcostal or tap or wound catheters. The key question is, are surgical catheter insertions better? This has not been fully elucidated or trialed. Ongoing trials are in place. The main problem is about the catheter insertion technique. So the surgical insertions in our place when we started used one of these sharp needles with a fenestrated catheter. So this is a catheter deposit technique rather than a catheter threading technique. So, and moreover, the catheters had different lengths and fenestrations. So choosing an appropriate length was a problem for the type of surgery. And moreover, the location of insertion was pretty variable, and especially the feel of it could not be adequately judged using sharp needles. So they ended up either they were wound catheters or rectus catheters or preperitoneal catheters. So, and teaching the surgeons to do the technique consistently was also an issue. From our local audit, what we found out was the surgically inserted catheters had a very high leak rate of nearly a third, and the fenestrated multi-orifice catheters had double the leak rates compared to epidural catheters. So we moved over from the fenestrated catheters to using only epidural catheters. And once we started to use surgical glue to close the hole created by the needle, our leak rate substantially dropped down. We also went on to look at ultrasound assessment of where the surgical catheters were. We found that this is a surgically inserted rectus sheath catheter, which is intramuscular. And this is a surgical catheter where the spread is seen under the anterior rectus sheath. And this is a surgical catheter which is present in the subcutaneous tissue. So nearly 60% of the cases were in the wrong place, and only 20% were present in the posterior rectus sheath. This was very similar to the findings in this recent study, which used surgical insertions of rectus sheath catheters, but they used intraoperative optimization with ultrasound. What they needed was 37% of the surgically sited catheters required ultrasound aid to keep them in the right place. And 6% of the insertions had a peritoneal breach. Our audit data, which looked at the efficacy of surgically inserted catheters and comparing them with ultrasound-guided insertions, we found that the ultrasound-guided insertion patients had much lower pain scores at both 24 hours and 48 hours at both rest as well as movement. And the average morphine consumption was half for the ultrasound-guided insertions, so 24 milligrams versus 47 milligrams. So we then moved over into predominantly ultrasound-guided insertions. So what I would probably say is part of the reason was all the surgeons were using transabdominal techniques. If your institute still practices surgical insertions, use a retrograde insertion technique, where the needle is placed in the rectus sheath first, and then it is tunneled backwards into the abdomen. So the Regional Anesthesia Society also recommends the high impact, low risk, widespread competence list of Plan A blocks. And the rectus sheath blocks are included in them as one of the key blocks. And this is a typical performance of a rectus sheath block, and then which will be followed by a catheter insertion. So we tend to do a single shot block first to create the space behind the rectus muscle. And then after that, follow it up with a 2He needle and then a catheter insertion into the rectus plane. Here you could see the catheter exiting the 2He needle. So the compliance with ultrasound-guided technique was much better after we introduced a specific pack which contained all the equipment that's necessary. So we introduced the rectus sheath kit, which contained a single needle, 2 catheters, and most importantly, a splitter device which allowed attaching to a single infusion pump. So practical tips for using regimes and pumps. The catheters can be connected to either elastomeric pumps or electronic pumps. Each has their own advantages and disadvantages. The elastomeric pumps, the patients are much more ambulatory, but they've got inconsistent delivery rates. Whereas with the electronic pumps, they have alarms, they can inject even when the catheter is kinked or under high pressure, and they're more reliable and can have patient-controlled options. So we started off using infusion protocols. The high-dose infusion protocol is 14 mils an hour, and the lower dose is 10 mils an hour with manual boluses via the pump or syringe as required for breakthrough pain. So as you could see from the plasma concentrations, if you connect an infusion after having initiated with a single shot block, you could connect them pretty much straight away. We then moved over into patient control techniques, which we believe performs better. So our patient control technique uses a 4 mil infusion baseline rate and 20 to 30 ml every 4-hour lockout. So if the maximum dose of local anesthetic has been used, we recommend connecting the catheters to the PCRA after 4 hours. But if the maximum dose has not been used, then they can be connected straight away. So this was our audit on comparing the continuous infusions versus the patient control regimes. What we found out was the number of times the patients had more than moderate pain was pretty much similar. The oral morphine consumption for the patients who had patient control regimes were substantially lesser, but they did not reach statistical significance. What was interesting was the total amount of local anesthetic that was used in patient control regimes were around 25% lesser. So which means that for equivalent pain scores, you use lesser amount of local anesthetic, and it is probably more safer, especially if patient goes to the ward setting. Rescue in AAA surgery, the use of rectus sheath catheters. So as Anton had mentioned, the use of thoracic epidurals has quite dwindled, and our experience with them has also substantially reduced. And the use of the acute pain team to manage it afterwards is not available all the time. So as a consequence, epidurals have a higher failure rate in institutes which don't have the backing up. So in our center, we had a 62% failure rate where the epidural was either stopped, paused, because the patient had motor weakness or hypotension. Patients then ended up having varying combinations of other techniques, which includes a PCA, a rectus sheath catheter, or a triple combination of epidural rectus and a PCA. We then looked at how the two techniques compared in elective and emergency abdominal aortic aneurysm surgery. So we looked at 2-year data in our hospital and looked at 66 cases which were alive after 48 hours and were not ventilated. So we arrived at 33 cases, and when we compared the epidurals versus the rectus sheath, we found that the number of times the patients having a pain score more than 2 was pretty much comparable at 24 and 48 hours between both the groups. The morphine equivalence was much higher in the rectus group just in the first 24 hours, but after that, they were pretty much similar between the epidurals versus rectus sheath. Greater number of patients were on vasopressors in the epidural group, unsurprisingly, and they were on it for longer. This is keeping in mind that more of the rectus sheath patients were of the emergency category compared to more of the epidurals being on the elective category. The length of stay was also similar, remembering the fact that the rectus sheath were all emergency AAA repairs. So far, we've done over 1,000 insertions in 8 years. We have only few complications: superficial cellulitis, intra-abdominal abscess. This patient developed abscess secondary to a rectus sheath catheter, but that patient was immunocompromised due to metastatic disease. 2 surgical insertions had catheters snapped and had retained foreign body. And 1 patient had a catheter migration, which was an intraperitoneal catheter. Catheter knots happened twice, and both the times the catheters were inserted more than 5 centimeters. All it required was a small skin incision to release the catheter, which was tugged under the skin. LA toxicity didn't happen. and in a few cases, they were stopped prematurely. So to avoid catheter knotting and to avoid infections, use a strict aseptic technique, remove the catheter when not needed in 3 to 5 days, and don't insert the catheter more than 5 centimeters. So this is a ultrasound video of a patient who had a rectus sheath hematoma. You can see the big hematoma in the wall of the rectus muscle, and it is predominantly present below the arcuate line. The rectus sheath catheters produce significant benefits in our ICU. They reduce opioid and opioid-induced respiratory depression and pulmonary complications. Patients can mobilize faster and they wean off vasopressors much quicker, which is a substantial benefit in ICU. So these are images of our patients who have had pulmonary complications secondary to use of opiates. This patient had aorto bifurm repair and came into ICU with respiratory failure. All he needed was reversal with naloxone and rectus sheath catheter sited. So this patient had emergency laparotomy, is mobile on day 1, performing his mobilization without any motor weakness. And this patient had emergency AAA repair, day 1, mobilizing just with rectus sheath catheters, no pain and no vasopressors. And in fact, he's even off monitoring and is ready for ward discharge. In summary, the rectus sheath catheters inserted as high as possible below the costal margin and between the umbilicus. So use a lateral to medial approach in plane. I use an in-plane single shot needle to create a space and a 2He needle to insert the catheter, and don't insert the catheter beyond 5 centimeters, and use glue to prevent any leak. If you're doing an elective laparotomy, a combination of spinal with opiates works really well, and post-op rectus sheath catheters, and use them in the patient controlled mode. And for emergency laparotomies, especially when they have stomas or drains, we insert the catheters post-operatively and run them on an infusion with a PCA. And if the patient is allowed to take orally, we take down the PCA and switch them to a patient-controlled regional anesthesia. Thank you very much.
Thank you, Madan. That was very comprehensive, especially the YouTube videos, your videos. We will now go to the question and answer session. We have a couple of minutes. We'll probably go a couple of minutes over the time period to try and answer some of the questions that the audience have posted online for us. A lot of the questions, thank you for all the interest. A lot of the questions I think have been covered by both Madan and Anton, but I've picked out a few choice ones. The first one is in terms of, there's been a couple of questions in terms of adjuvants and adding adjuvants, and I think Anton presented some interesting evidence on that. From a practical perspective, Madan, do you use any adjuvants in any of your rectus sheath blocks?
I have used fentanyl in the rectus sheath. It seemed to work really well, but I was shot down by pharmacy for mixing drugs, so I stopped using it.
Yes, yeah, we get our hands slapped amongst many other things by our pharmacy colleagues as well. Anton, from your end, do you use any adjuvants in your hands?
No, I haven't been able to, but likewise, what I would like to have done is use our epidural solution, which is 0.125% bupivacaine with 2 mics per mil Ventolin. And I would like to use that as our rectus sheath catheter infusion, but so far not been able to.
Yeah, that seems like a ready-made solution for us to try, isn't it? Indeed. Yeah.
Yeah, those are our standard bags that are used for epidurals, ready mixed.
Yeah. Another question is on the protocols, and Madan had illustrated very eloquently the regime that is used by his center, and it's interesting to use the combination of continuous infusion and patient control boluses. In Blackburn, Anton, what regime are you using at the moment?
So we started off using 4-hourly boluses delivered by the pump, by the ambit pump. So it's still needed. That was before the patient-controlled pumps. Well, they were patient-controlled, but we weren't successful in getting our patients to engage in pressing the pump. despite as much education as we could do. So maybe it's a northern versus southern thing in the UK. So we ended up having to rely on staff to press a button for them. And that wasn't, you know, we didn't get good enough compliance. We would get agency staff at night end up not doing it for us. So that was why we moved over to continuous infusion, just to guarantee delivery. But yeah, I'm still open to both, but we started off intermittent, we moved to continuous.
Our compliance is pretty poor as well, in the sense, it's not to do with the patients not pressing it, it's to do with our prescription rates. Vast majority of people are still very comfortable just writing up the infusions. And again, it's a change of practice. We audit our use of patient-controlled every month, and then we nudge people to change things and change the prescription.
Yeah, likewise, in Blackpool, we're still with the ambit pumps, but we use the fully automated intermittent boluses. So it's a 6-hourly bolus, and we find that takes out the compliance side of things, and we've not had any issues in terms of adverse events or side effects from that perspective, and we find the pumps to be fairly reliable. The question about insertion of catheter, whether we do it pre or post-operatively, and I know Madan illustrated in certain procedures, like the emergency laparotomies, you would do it post-operatively. Is there any other practice from your side, Anton? Do you do it pre-incision, and how much of the anatomy does it distort?
So it very much with us depends on who's involved and what sort of surgery it is. So despite the randomized trial we conducted, we really didn't get the buy-in I thought we would get from anaesthetists being interested in learning the ultrasound-guided technique and performing it. So we still ended up really with just a few enthusiasts who are keen on the ultrasound-guided. So the technique has really become mostly surgically placed in my hospital. Personally, I think the better efficacy is an ultrasound-guided placement pre-incision. So straight after induction of general anesthetic, you know, bolus it up, have it running, run it throughout, etc. But the best technique is the one that you can actually get working. And we have got good buy-in from our surgeons now. I don't think it is as good quality as what Madan illustrated with his data, but there is also a lot of variation. I think it very much depends on individual surgeons' enthusiasm and their own individual attention to detail when they do it. So we almost all of our emergency laparotomies have surgically placed catheters, and they seem to work fairly well. I'm an intensivist and I see them all the time post-op, and we seem to get quite good results. If they're stable emergency laparotomies, in other words, they're not septic and hemodynamically unstable, we use the spinal opiate, even the emergency group. So that hybrid technique is very, very, very useful.
Indeed, yeah. Likewise, it must be a northern thing. We use a lot of intrathecal opioid for the both elective and emergency laparotomies, and we get good results in combination with the rectus sheath catheters. And likewise, we had excellent buy-in from our surgical colleagues, and I think they've been a real big cheerleader in terms of the use and introduction of rectus sheath catheters on my behalf, purely because I think they see the outcomes, the excellent outcomes that we get from it, especially when the alternative is, if you can't have a epidural, is well, just systemic opioids, which is really a poor alternative, isn't it? Yeah.
I think the other thing is just the practical aspect of time. That emergency group, you're keen to get them on the table and start surgery. Yeah. So it's not really ideal to do two techniques in the anesthetic room. So if the anaesthetist is going to pop in a quick spinal opiate, you don't want to then go and do an ultrasound nerve technique as well. So by and large, they get an intrathecal morphine popped in off to sleep, and then the surgical catheters at the end.
Absolutely.
But from a practical perspective, inserting them post-op is slightly tricky with the dressings being placed already. And with closure, what happens is air trapping happens in the skin and subcutaneous tissues. So it can be slightly tricky to do them post-op. Similarly, pre-op placement is a problem because the catheters, when you insert them quite far enough, you don't know the direction of their travel. So they can get enclosed in mass suturing technique, and they may be difficult to pull out afterwards. So we always do it post-operatively, and it may be slightly tricky, but if you go laterally quite out in the abdominal wall, it's generally not a problem.
Yes, just a couple more questions on the adjuvant. So Madan, what's your experience in using other forms of adjuvants like dexamethasone and adrenaline, and does it really make a difference, you think?
I don't think it makes a great deal of difference. We'd rather give it IV rather than giving it in fascial planes. We've had one case of surgical untoward incident where bupivacaine with adrenaline was used, and it was then incriminated whether the patient developed a rectus sheath necrosis post-operatively. So, and then it was blamed on the bupivacaine with the adrenaline that was used. But it was probably the patient was pretty unwell. That may be the primary reason. So we don't use adjuvants to reduce the peak absorption of our plasma concentrations in the rectus sheath plane.
Thank you. And Anton, from your point, how about things like Dexter or clonidine? Do you think there's a role for that in mixing it with the rectus sheath catheters?
Well, that one study I presented from China looked promising, and it was particularly in terms of, well, they reduced opiate consumption, PCA usage, and it did seem to prolong the block. So dexmedetomidine does look potentially of benefit, and so does, as we said earlier, adding opiate. I came across one study looking at adding adrenaline, and that didn't seem to make any difference. So there is one published study comparing with and without adrenaline.
That's great.
So I wouldn't bother with the adrenaline.
No, fantastic. And I think on that exciting note, I think that is the end of the webinar. We've gone over a couple of minutes, but we had a lot of questions. Some of them were unfortunately couldn't answer directly, so apologies for that. But I think a lot of the questions posted were answered in both the speakers' excellent presentation. So many thanks to Anton and Madan for taking the time to present the good work, and many thanks to both ESRA and Pajunk for organizing this webinar. And the recording for this webinar will be available on both the Pajunk YouTube page as well as the ESRA site in the very near future. So thank you very much for your time and attendance, and have a nice rest of the day for everyone. Thank you.
Thank you, Andy.
Thank you very much, Andy.